I am going to talk about CF. Again, this is a disease I've been helping take care of people for my entire career, and I've seen this disease move from a universally fatal disease to a chronic disease. Yet there are some people out there who have advanced CF who require more than medicines, and so we're going to go over all of that today. Maybe. Just a couple disclosures. I think I talked about the objectives, but I really want you to understand some of the epidemiology associated with cystic fibrosis. We'll talk about how to diagnose it. And these are things that I didn't know. I mean, I last saw, before I went to fellowship, a person with CF in pediatrics as a medical student because we didn't have the exposure here as residents. And I think that's something that I learned through fellowship. And for folks that don't have the opportunity because of exposure, it's important because this is a disease that is much more common than we think. We're going to talk about standard therapies and then some of the newer therapies that have really made this exciting. I talked about Alan. This is Alan here. And this is how I remember him. Happy, smiling, willing to help, and willing to help med students get to the next step. And again, this is an incredible honor for me because he was such a good person, such a good teacher, but he was also a good friend. And as I talked to Diane and John last night, I miss him. You know, not that we were the best of friends, but if I came down here, I would have expected him to be in the audience and we would have had a chat afterwards. He would have told me a little bit, I would have told him. So it is a great honor for me to be here, to represent and to do my best to honor Alan. This is Dorothy Anderson, and in 1936, she described cystic fibrosis. She went to Holyoke College and then came down to Johns Hopkins for medical school, where she graduated with honors. She soon moved on as a surgical intern to Strong Memorial in New York State. Did fantastic there, but they said, you know what? You can't be a surgeon because you're a woman. And she basically just said, all right, well, I'm out of here. She went to Columbia. She became a pathologist, and it was doing autopsies on 4 young children who had died prematurely, where she discovered cystic lesions in the pancreas. And she coined the term cystic fibrosis of the pancreas. And it was her first description of this disease that led her to discover the screening test for CF, which is known as the sweat chloride. So she helped develop that test. Surgeons lost out and medicine gained a leader. So we're indebted to her and her pioneering because she figured out some of the beginnings of this disease. This is Danny. This is Danny Bissett. Danny has allowed me to share his name. Danny is a patient of mine. He grew up in McLean, and he has been a patient of mine for over 20 years. This is Danny on the cover of Science magazine in 1989 when the gene for cystic fibrosis was discovered, CFTR, the cystic fibrosis transmembrane conductance regulator. It was discovered by 2 teams simultaneously, one at University of Michigan and one in Toronto. And Francis Collins was part of the team in Michigan. And this picture was taken 20 years after the discovery of the gene. By this time, Danny had 1 lung transplant. So even though we have discovered the gene for a single gene genetic mutation, it highlights the stark reality that even though we discovered it, we had no cure 20 years later. Danny came to a international conference, and so did Francis Collins, and they shared an exchange. Danny thanked Dr. Collins, and Dr. Collins thanked Danny for his samples in helping to discover this. And it was a pretty moving presentation. This is the protein channel, CFTR, which is a chloride channel that's located on the apical cell surface of all epithelial cells in the body. Functions as a chloride channel, as I said, but it also highly regulates the sodium channel that's next to it. When CFTR doesn't function, chloride doesn't flow properly through the cell, and so that sodium channel is overactive. And so it draws sodium into the cell and with that water, and that's why in the airways and all the epithelial line cells of the body, you get that thick, sticky mucus. And that is what leads to chronic pulmonary disease in people with CF. There are over 22,000 different mutations of this. The most common is the F508 del, right? That's the one you're going to see on an exam. That's the one you're going to see if you, most likely, if you're going to do genetic testing on these folks. And here's a representation of a normal airway. So you got CFTR working properly. The cilia look good. There's a mucus layer above that, and then you got bacteria moving as the mucus travels. This is what happens with CF. As I said, that sodium goes in, water goes in, that liquid layer is depleted, the cilia go down, mucus builds up, and this is the perfect setup for inflammation and infection to occur. This is likely not going to work. Oh, it is. So here we go. Here's a representation. This is the cilia moving back and forth normally, and we're going to zone in on CFTR, chloride channel working perfectly, chloride going out of the cell, sodium channel going into the cell behind it. Now CFTR doesn't work, chloride stops, more sodium goes in, water follows sodium, we lose that liquid layer, and then everything gets stuck, setting up for infection. There are both classic and non-classic forms of CF. The classic form involves the sinuses, the lungs, the GI tract, the pancreas, the vas deferens in men, the sweat gland. A non-classic form might be somebody who's been diagnosed with asthma, or maybe has a little sinus problems, or maybe just was underweight all their life. And those people are usually diagnosed later in life. Our oldest patient just recently passed away. He was almost 85 years old, and he was diagnosed at age 75. And so, you know, as we look for these things, as we look for it, we find it more and more. There are some diagnostic criteria, and these are simple. Usually you have to have clinical findings, so the ones I just mentioned. Then you have to have laboratory evidence as well. So you could have a sweat chloride that's positive. We could send your blood away and you could get genetic testing and you could have come back with a known genetic mutation for CF. If you got clinical and laboratory, you have the diagnosis of CF. We also have the ability to directly measure chloride transport in the nose in vivo, and that's known as a nasal potential difference. And then we also have a protocol where we can sample nasal epithelial cells, grow them in the lab, and test them to look for CFTR production and function. A sweat chloride of over 60 is termed positive. I see a lot of patients with borderline sweat chlorides. So when the sweat chloride is in between 30 and 60 and they've got some lung disease, then they get sent to us and then we have to try to figure it out. Is this CF or is it some other disorder that is like cystic fibrosis? What happens when people have CF and CFTR is not working and that thick, sticky mucus builds up in the lungs? They are at risk for characteristic organisms. The most common organism to get for an adult is Pseudomonas. The most common organism for a child to get is Staph aureus. And the varying prevalence of these organisms changes over time. And there are some rare organisms that we see. I've become very facile with antibiotics over the course of time. I feel like I should have done an infectious disease fellowship, but I guess I've learned on the fly. People with CF develop bronchiectasis. And here we can see thickened dilated airways with a signet ring sign here. One of the arrows is pointing to that. And unfortunately, this can progress to what's called cystic bronchiectasis. And you can see that on the left-hand side. And then there's almost hepatization of the left upper lobe. It looks like a liver because of chronic infection and inflammation and fibrosis. This is my favorite slide whenever I give this presentation. Just in my career, I've seen a dramatic improvement in the survival in people with CF. When I started fellowship, the median predicted survival for someone with cystic fibrosis was about 28 years. Prior to COVID, the CF Foundation released their updated data. They haven't released anything since because I think they're waiting for this year's meeting and for some of the newer therapies to kick in. But as of the last data cut, median predicted survival had improved to 50 years. And so much so that there are more adults living with CF today than there are children. So we have more adults in our adult CF program than there is in the pediatric program, which is crazy. And we have one of the largest CF programs in the country, if not in the world. And so it's been incredible. And this is not due to just one thing. In part, it's due to the Cystic Fibrosis Foundation. We used to, they have since passed, but we used to take care of brothers whose mother was a volunteer for the Cystic Fibrosis, and she helped develop the Cystic Fibrosis Foundation, which was started by a bunch of parents because they wanted something better for their children and figured, you know, we can figure this out, and then let's get the doctors and the researchers involved. And so she was a volunteer for the Cystic Fibrosis. And for those that know the CF Foundation, one of the logos is a rose, and underneath it says 65 roses. And the reason for that is one of the brothers said, "Mom," she's always on the phone trying to raise money. "Mom, why do you work for 65 roses?" And she's like, "What are you talking about? I work for cystic fibrosis." But he thought she was saying 65 roses. And so I have a patient who, after her transplant, she had a wood carving made of 65 roses that she gave us as a team. And it's, again, it's a very special thing that this disease was not only conquered by scientists, and doctors, and caregivers. It was really because of the care of parents and the desire for their children to live longer that we are where we are today. This has led to improved nutritional support. Canada was always better than us, so we followed Canada's lead, and we told people to just eat lots of fats and eat as much as you want, because improved or increased weight was associated with better outcomes. Then medications were developed, Dornase alpha, which broke down mucus, hypertonic saline, which came out of patients in Australia who were surfers who got crashed by waves with CF, said, "God, I feel so much better after I inhale all this salt water because I just cough everything up." And so the researchers in Australia said, "Well, geez, there's got to be something to it. Let's just nebulize some hypertonic saline and see if they get better." And sure enough, it helped reduce exacerbations and improve lung function. Inhaled antibiotics were invented. Now we have a pharmacy that can make any antibiotic to inhale. So I've tried everything with these patients. Newborn screening is mandatory in every state of the United States now. This is not something that was around when my children were born, and they weren't born that long ago. But now there's newborn screening that is mandatory for everyone. So we are detecting cases of cystic fibrosis earlier. Quality improvement initiatives. The Cystic Fibrosis Foundation has over 170 centers that are accredited to take care of people with CF. And there are specific guidelines that we all follow in caring for those. And then finally, and I'm going to go into some of these, there are now cystic fibrosis protein, the CFTR protein modulators, medications that are designed specifically to correct the protein problem, which has changed the lives of over 90% of people with CF, to the point where I don't even feel like a lung doctor anymore. I feel more like a psychiatrist because we are talking about other things other than cough and sputum and shortness of breath. We're talking about, well, how do I deal with life now? I'm like, well, I think you need a psychiatrist because I don't know how to deal with life sometimes. Um, um, so we'll skip over that. Pulmozyme or Dornase alpha was the first medication to show an improvement in lung function. And patients nebulize it. It takes about 2 minutes, which is great, but you have to be connected to a nebulizer, right? So it takes away from your life, but there was an improvement in lung function and a reduction in exacerbation. And the same thing with nebulized antibiotics. And the two standard ones that we use are inhaled tobramycin and inhaled aztreonam. And both of those showed over time that there's an improvement in lung function and a reduction in CF flares or exacerbations. But again, these take a long time to do. The nebulized therapies, when I was a fellow, Dr. Boyle had us sit down and we timed how long it would take to nebulize everything and laid out like a standard medicine regimen for a patient. And it took us about an hour and a half to set everything up, get everything running, make sure we did everything. That's just once a day, right? So we're asking people, patients, to do sometimes 2 and 3 times a day, 3 hours out of your day to do stuff. I can't even remember to take one tablet of an antibiotic if I have to take it 7 days for something, right? And we're asking these patients to do this every single day, 3 hours out of their day. Crazy. And here's the hypertonic saline study where there's an improvement in lung function over time. And then finally, so nebulized antibiotics, nebulized mucolytics, airway hydrators, and anti-inflammatories. And we used azithromycin, which also caused an improvement in lung function and a reduction in exacerbations based on a disease called panbronchiolitis, which happened in Asia, and it was treated with erythromycin. And because it was thought that erythromycin had anti-inflammatory properties. So a study was put together using azithromycin, and sure enough, people with CF had an improvement in lung function and a reduction in exacerbation. So for years, we had quality improvement projects in our center to make sure that everyone was on these 4 modalities to make sure that they were getting optimized therapies. And it wasn't until recently that we were able to actually treat the underlying disease. The specifics of this are not important, but there are a lot of genetic mutations. I said there are over 2,000. And if we break those up into different categories, not a geneticist, but if you get protein that's made and the gene is telling that the protein needs to stop, only a little protein is going to be made. And then the cell is going to destroy that. So that's a type of mutation. You may have a protein that's made that's misfolded. It gets in the cell, but the cell recognizes that a problem, and so it destroys it. That's a different kind of mutation. The protein might get to the right spot, but it may not open as a channel. That's a different mutation, and so on. So there are different classes. And one class in particular, that protein that's made that gets to the apical cell surface but just does not function, was the first mutation that was targeted because the CF Foundation partnered with a company, gave them $200 million to say, hey, find something that is going to change the configuration of this channel and open it up. And at the same time, a high schooler with a supercomputer was doing the same thing. So $200 million, company, Vertex, figures it out, creates a medication called ivacaftor. Soon after that, that high school student found the same thing. So, the next generation, look out, right? We're old people. You guys are going to figure things out. And as we talked about this last night, we talked about artificial intelligence and how things are just moving so fast. I wish you had read the AI report that came out on me, or that you did, right? As a joke. Um, so so this medication was studied in a genetic mutation known as the G551D mutation. It was given to 14 people in the United States. We had one patient who we gave it to. Um, and she was actually in the randomized control part of the trial. She wound up getting control. She had been trying to get pregnant for years and years and years. When the control arm rolled over to the treatment arm, she immediately got pregnant. And it was proof of concept. And she had had her cervical mucus viscosity measured before, and she had very, very thick cervical mucus. And that was thought the reason why she was not able to get pregnant. Once she went on this medication, although we didn't measure her cervical mucus viscosity, she got pregnant within a month. And that was our light bulb in the head. Oh my gosh, this is really, really working. This medication was published in the New England Journal in the 2010s, and it was approved by the FDA in 2012 for that specific G551 mutation, G551D. Over the course of time, the different mutations that this medication ivacaftor was approved for had increased to in the 50 range, but still we had over 2,000 different mutations where this didn't work for. Ivacaftor also decreased sweat chloride in the normal range. One of the things that I recall seeing kids when I was rotating through pediatrics is a parent would describe kissing their child and tasting salt. And that's because of the sweat chloride that came out. This goes away. Patients actually say, I'm less salty now when I exercise. It's crazy. And so this was a miracle drug for a limited population, though. It improved lung function faster than any medication that we had observed.
Yes. Here. Yeah. See, did you have any abnormality?
Okay. It improved lung function faster than any medication that we had observed. And patients described what is called the purge. Take the medication for a couple days after, they cough stuff up, and then no more cough, no more shortness of breath, no more sputum production. I didn't think it was real, but then everyone started saying it. And now it is a very common phrase to talk about the purge and how you felt afterwards. Soon after that, there were two other combination medications. So lumacaftor was added to ivacaftor, and tezacaftor was added to ivacaftor. And these were FDA approved for the most common mutation, the F508. However, there wasn't that improvement in lung function. There was a reduction in exacerbation, but that 15%, it just wasn't there. And patients realized that. They weren't feeling it. And so the foundation, fast forward to 2019, found another medication, and that was known as elexacaftor. So the combination elexacaftor, tezacaftor, ivacaftor, known as Trikafta, was FDA approved in October of 2019 for any person with CF with an F508 del mutation. And so this was now approved for over 90% of people with CF. This was the fastest approved medication to date by the FDA. And funny story, not really. We had applied to our IRB for compassionate care usage in January of 2019. And our IRB was still looking through it by the time the FDA had approved it. We wrote some letters to our IRB about that. Yeah, yeah. And here are the basic science results. And this is what we do in the laboratory for folks who have mutations that we are unsure if it's going to work in. To sort of simplify this, on the y-axis is chloride transport. And there's a line, a horizontal line there across 50. That's what we believe chloride transport should be if someone just has one copy of a mutation in the CFTR. So you're a heterozygote, you don't have CF, but you don't have full chloride transport, but you don't have disease, right? And so our goal is to get chloride transport through medications to above the 50%. And you can see the TEZ, IVA, and then this VX445, which is elexacaftor. And the different combinations, and the three used together, if you have one 508del mutation or two 508del mutations in bronchial epithelial cells, brought that chloride transport up to above what we believe a heterozygote would have. And so in the laboratory, this pretty much cured the disease. And this is fantastic. Now, what did it do clinically? Improvement in lung function by about 15%, a reduction in exacerbations by 60%, normalization of sweat chloride, and a significant improvement in respiratory symptoms. So all the things that the FDA would need to approve this, and all the things that as a clinician we would want to do to help patients. And here's sweat chloride moving into the normal range. I'm just going to move through this. So elexacaftor, tezacaftor, and ivacaftor improved outcomes significantly. And the North American Cystic Fibrosis meetings, which were held in November of 2019, everyone was super excited because the paper had just come out. And we were excited to get back home to prescribe this medication, which also may be one of the fastest uptake in medication prescription for a medication in the history of medications. Because patients were coming in just to get it and calling us saying, can I come into the office or can you prescribe this? Before we could even get them in. Unfortunately, CF is progressive, and you can see that lung function falls here over time. And traditionally, lung function falls in between 2 and 4 percentage points per year over time. And this, unfortunately, for some who develop advanced lung disease, even the medicines that were available, even the early on modulators, disease would progress. And at that point, the only option was a lung transplant. You can see here over time, the number of lung transplants in the United States has increased. This is all lung transplants, double and single, over time. CF was initially thought as a contraindication because of all the infections. But as you can see here, the number of lung transplants has increased over time, up to about 2019. And if I updated this, last year there were 40 lung transplants for cystic fibrosis because of these medications. We're now seeing an increase because there was a delay in the progression of disease, which did not prevent progression, it's just delayed it. But as you can see here, there's a significant, in between 200 and 300 lung transplants done per year for someone with cystic fibrosis. And fortunately, survival is improving over time. And for someone with CF, as you can see here, if you've had a lung transplant, survival is the best. So median predicted survival for someone with cystic fibrosis is about 10 years. Whereas the other diseases, median predicted survival is not as good. Now, if we compare survival to other solid organ transplants like liver transplants or kidney transplant, or even heart transplant, these survival curves are abysmal. So we need to figure it out. For cystic fibrosis, it's longer, but it's not acceptable. We know that delaying referral negatively impacts and worsens outcomes for people with CF. So we push people to refer earlier. This is a study done by Kathy Ramos at the University of Washington in Seattle, where she looked at people with advanced lung disease and an FEV1 of less than 30% predicted. And you can see here, there's a significant number of people who died before they were even able to get a transplant. This is all CF patients. And this happens over the course of time, suggesting that we are not moving fast enough for this population. The reason why those survival curves are where they are is because of problems that happen afterwards. There's primary graft dysfunction, which is like ARDS immediately after coming out of the operating room. People get rejection, acute cellular rejection in the first year, and afterwards they develop antibody-mediated rejection, infections, and then eventually everyone develops chronic rejection. And then we always have to worry, because this is an immunosuppressed population, about the development of malignancy. We got to thinking that there is a journey for someone with CF who has advanced lung disease, who needs a transplant. In CF, we've figured out the transition process for someone who's a kid taken care of by a pediatrician and a pediatric pulmonologist to move over to the adult side, because we have transition clinic. I go to that. I meet the parents there. We talk about differences, and we get to know each other over time, and then eventually they are transitioned over to the adult side. The lung transplant world, that was not like that. You had advanced lung disease, you got punted to the transplant team, and you were never seen again by anybody else, which scared the CF patients to death. And so we thought, we need to make this better for them and figure out a transition process. And the goal was to help improve that, that timing. Because when we surveyed patients, they told us that we discussed this too late. We referred them too late. I was afraid that I got sick, or I became too sick to get referred. And then, I was afraid that the timing might negatively impact me. So we sent this to people with CF, and we sent this to providers, and they said the same thing. So we, again, thought that we needed to figure this out. And people wanted to talk about this. We were afraid to talk about the transplant because, oh gosh, I'm failing you. I'm failing you because of medicines. But patients wanted to talk about it. So in 2017, we had a meeting at the CF Foundation to talk about potential proposals of how to improve outcomes in people with CF. And the CF Foundation bought it and said, okay, yeah, we'll let you work on it. And so we said, well, why is this important? Because delayed referral, this was done by one of our fellows. So if you are sicker and referred for a transplant, your outcomes are worse. You're more likely to die. In the first 3 years after a lung transplant, if you're referred late, go into it too sick. And so, this is a sign down below, which needs a little bit of trimming. I think I can only see Saxa now when I drove by it. But what rocks? Transplant patients were saying, okay, I get it, but I feel abandoned now by the CF Foundation, because now I've been transplanted and they don't care about me. And again, they felt like they had failed CF care because the medicines didn't work, and these were before modulators. But again, that feeling was heard by the foundation. And they put together a cystic fibrosis transplant consortium. And this started with 11 centers in the United States and Canada, where we were focused on 4 different things: basic science, clinical research, guidelines and best practices, and then quality improvement. We came out with new guidelines for referral for people with CF. This is like a 25-page document. It's very complicated. It's got a lot of tables in there. I got to look at it all the time. And now it needs to be updated. But in any event, the foundation sponsored that, and we were able to put that together in a very short period of time. Now, at the same time, this is a paper done by our transplant surgeon and the transplant team. So Errol Bush looked at outcomes after a lung transplant. If you're transplanted at a program that has a cystic fibrosis, remember, this is a multi-system disease, so it's not just the lungs. They got diabetes sometimes, liver problems, GI problems, and specialists need to recognize potential complications before they happen. And so there's a dramatic difference in survival if you're transplanted at a center that has an attached CF center as opposed to not. And this got us to thinking more that we really need to figure out this transition process. So we put together a quality improvement initiative with the initial 10 centers in the consortium, 10 lung transplant centers, and we got their referring cystic fibrosis center together in the same room, which would have never happened 10 years ago. No one talked to the transplant folks. I'm a transplant pulmonologist as well, and sometimes I have a difficult time talking to myself about wearing the 2 different hats because I think differently. So we got everyone in the same room to have the shared purpose in creating that transition process. And that started with those 11 paired centers, moved on, and then moved on to a regional disseminated network of over 50 different centers now, where we share the same guidelines, the same processes. If there are questions, we have everyone's cell phones. We can ask anything. We have a listserv. It is a fantastic resource. I'll give an example. A young woman from Alaska was looking to be transplanted, was going to different centers based on her insurance. We all talked about her because we all had cell phones. Did you see her? What do you think? What do you think? Because she had certain infections. She eventually wound up getting transplanted at UCSF, and I got a text from the director there 2 weeks ago saying she's doing great. She says hi. And this never would have happened without this initiative. We have put together best practices. We've put together a compendium of how we approach the process. We've put together books that we provide to patients that explain the transition process that to make this easier on, and this is an ongoing effort. We had our most recent national summit in Baltimore, and we have our concluding national summit in Santa Rosa in June of next year, where we're going to wrap this up and then hopefully publish some best practice guidelines to at least turn this over to the CF programs. And here's just a little bit of the research that has been done. And this is a graph. And if you just focus on the colors, green is good, orange is bad. And we looked at the different sites and the different sites and how people communicated with each other, frequent communication, timely communication. Are you communicating the correct information? I mean, I remember specifically years ago walking down the hallway and parents walked up to me and said, "Did you hear about so-and-so?" I'm like, I thought she died. But no, she got transplanted and no one had told me. And I flipped out. I'm like, how could no one tell me that this happened last night? right? So communication key, shared goals, shared knowledge, mutual respect. And you can see that during this quality improvement initiative that we put together for all of these sites and the paired teams, there was a dramatic improvement in all of these indices, meaning that we were now talking to each other and talking effectively and making sure that we're doing what we're taking care of these patients in the best way that we can. And the main goal was to both standardize and optimize care. But another goal came out of this during this whole process, and that was just not just to focus on people with CF, but then extend the lessons that we learned to other disease categories or maybe other solid organ transplant programs like liver, kidney, heart, small intestine here, right? That this process can help improve outcomes. And I failed to mention that when we look nationally, the teams that improved most in those indices, when we linked those teams to national registries of lung transplant outcomes, those teams that improved most had the best outcomes, best survival. And so that was huge. That was a huge, still need to get that out. Need a resident or a med student to get that off my table. But very, very important that we not just focus on this one disease, but can we apply it to others? And we brought that to the CF Foundation. They said, sure, yeah, we can help you out, which is fantastic. Fantastic organization. Let's use the things that we learned and apply it to something else. And I'm going to stop with just a few pictures. This is our team. There's another Georgetown grad there, Mark Jennings on the right side in the back. Jonathan Grant is our pharmacist. And this is the first day that we were able to prescribe that triple combination medication. And we gave it to 10 patients that day. We were so excited. And since then, most people that are eligible for this medication are prescribed it. This picture is, I took this in Nashville in 2019. And the little head on the bottom, that's Francis Collins. Francis Collins came to the meeting, came out Nashville style, sat on a chair, on a stool, brought his guitar, and sang a song to us about cystic fibrosis that he had written 30 years before when the gene was discovered. And it says, and actually, this was the chorus and we all sang it, but it sounds corny, but it was really, really moving. And it says, dare to dream, all our brothers and sisters breathing free, unafraid, our hopes unswayed, till the story of CF is history. And for you all out there who are in training, you're going to see this disease be cured. And the next generation of medical students are going to learn about this, but it's going to be a historical disease. And there aren't many diseases that I can count on. I mean, I could probably count on one hand the diseases that have been cured, right? And we are in a fantastic time of medicine right now. So remember this. I have med students working in clinic, and I say that every week. Like, Dr. Merlo, you said that to me last week. Like, I go, I'm getting old. And then finally, if you do get a chance, the cherry tree is outside in front of the medical school. There's a nice plaque out there, dedicated to Alan. And I really hope that he is looking down on us right now and smiling.